Good morning. Welcome to all of you. I'm very excited to see everyone here, and I hope you really do enjoy the conference. The local planning committee and the program committee worked very hard to make this a good learning, educational, scholarly opportunity for you. I do have the opportunity to introduce Dr. Robin Newhouse, who, when I grow up, that's what I want to be like. I have had the opportunity to meet her at a couple of other forums, and it's just been so wonderful and interesting to listen to her. She's been an integral part with regards to generating nursing research and evidence-based practice. She's at the University of Maryland School of Nursing and has done wonderful, wonderful things for the nursing profession. She is very, very integral with PCORI, the Patient-Centered Outcomes Research Institute. So that's a little plug for that, because that's a wonderful funding opportunity for nursing, and then also to engage your community stakeholders as well. So if you want to have like an hour worth of reading, Google her name, and you will find all kinds of things there. So without belaboring time, because I know she has a wonderful presentation for you, it truly is my honor to introduce Dr. Robin Newhouse as our keynote speaker. Thank you.
And I am absolutely delighted to be here. I say for a couple reasons. First of all, I checked with my husband, and there's 10 inches of snow in Maryland. So I got here in time. And second of all, I can't think of anything better to focus on than how we as nurses can improve the value of what we do. But before I start, I want to just say how excited I am to see how many of you have received SNRS grants. As I was walking in this morning, I saw Pat Messmer, and she reminded me that I was an A&F scholar. She just published a paper to list all of the A&F scholars, and my first grant actually was my small A&F grant. So when I see you stand up to say that you received an SNRS grant, I look 15 to 20 years in the future, and I see a productive research career. So congratulations to you all, and I just am excited that we have a professional organization that supports the generation of new knowledge. All right, so let's start. Enhancing value-based care. Well, I'm just going to start by saying we live in quite a time. I guess you could say it's the best of times and it's the worst of times. It's a paradox, right? So today we have all this exponential growth in knowledge, in information, and we know about the genetic codes, and we've done wonderful things with technology. And yet, in terms of quality and safety, much of the evidence hasn't been transferred to clinical practice where people could receive what we know works for them. We've often not done what we should do and have done what we shouldn't do. So it's a great time to think together around this whole idea of bringing value to the patients that we serve. So just some data to increase the urgency of this problem. So estimates suggest that if the quality delivered in the highest performing states in the United States was provided in all of the states, there'd be 75,000 fewer deaths in 2005. That was from 2005 data. Wasteful use of resources in healthcare cost $750 billion in 2009. So, and it's not because of the lack of knowledge. In 1970, there were 200,000 medical journal articles, and in 2010, there were 800,000 medical journal articles. So it's not that we don't know either. For some of our oldest population, 50% don't have the preventative services they should get. Those older people with comorbidities take up to 19 medications. They see 7 providers across 4 practices. So truly, our healthcare organization is very complex and not delivering care the way that we should. And yet, the Institute of Medicine, in some of their learning healthcare system work, has set the goal by 2020, 90% of clinical decisions will be supported by accurate, timely, up-to-date clinical information and will reflect the best available evidence. And in order to get there, it's 2014, that's 6 years from now, we have a long way to go, and it's going to take each one of us in the room, whether we're knowledge translators or knowledge generators, to pitch together and join the solution to these problems. So let me just start by asking you to think about a couple questions. And I'm not going to ask for you to raise your hand, but the title of the conference is around enhancing value-based care. So think to yourself, what is value-based care? And as you think about from whose perspective is value assessed in your definition. Ask yourself what healthcare processes that you're involved in actually provide value. And then get yourself to what questions need to be answered to generate and enhance value for patients. So when we think about value, we're really thinking about something that's important, something that's of worth. So I'm going to think more in terms of value around quality, delivering interventions that work for people around some of their most difficult problems, as opposed to the cost effectiveness that's really quite different, because often we know by improving quality and decreasing the variance in care that we delivered, we actually decrease the cost of care. So I take the lens that value is for patients. Everything we do as nurses, and I would say most of us are in the nursing profession because we want to care for patients. Most of us that do research, the end product is patients. So I'm just wondering, now I'll ask you to answer. I conduct research for patients, okay? Patients. So if you're familiar with some of the Institute of Medicine reports, and if you're not, I would encourage you to check these references. You can download these reports. It's got some of the best experts sitting at the table trying to solve some of the most difficult problems, and I call your attention to two in particular. I have them on this slide. One's Best Care at Lower Cost, Path to Continuously Learning Healthcare in America. And that was published in 2013. And there was a IOM roundtable in the fall of last year, and I think it relates appropriately to those of us that are in clinical arenas and those of us that are conducting observational studies. So some of these thoughts come from these reports, and that one is called Observational Studies in a Learning Healthcare System, and that just came out actually last week. So it's pretty phenomenal. So when we think about a learning healthcare system, according to the IOM definition, is one in which science, informatics, incentives, and the culture of the healthcare system align to create continuous learning. So the idea is that the evidence that's generated is embedded into the healthcare system. And I'm not talking about one arena of the healthcare system, I'm talking about across the healthcare system. But you'll see in the IOM report from this graphic, and this is from the Best Care at a Lower Cost, that we're generating science, plenty of science, but the insights of that science are poorly managed. And when we have evidence, the evidence is poorly used. And when we deliver care, the care that we deliver is poorly captured. And I know we're doing great things in electronic medical records to be able to capture more of what we do digitally. But the end product is the patient experience. So you can see just from this graphic the opportunities that we have to really focus on value and improving value now for tomorrow. And the view is that really it's a different approach. We have plenty of technology to support us. We haven't done such a good job partnering with patients and clinicians and communities. We still are isolated in the trajectory of healthcare that we serve, but we've got to do a better job here coming together to drive this feedback loop from science to care, science to evidence to care. And I would say it's dynamic as well. So some of what I'm going to say is really part of the healthcare system, learning healthcare system philosophy that's the Institute of Medicine supports. So in our brief time together, what we will do is think about the opportunities that we have as scientists. And what I'm going to say is, I'm going to tell you now what I'm going to say, but I hope you don't drift off in between the beginning and the end. But first I'm going to say what we do in terms of generation of knowledge is incredibly important. Be bold, go big, do something important. We've got to have far more effectiveness studies. So I live in the pragmatic world, and I value evidence that can be translated clearly. So we need to do a lot more around our effectiveness studies and making sure we know what works for who and in what situations. We not only need effectiveness studies, but we also need to focus on implementation science. So there are some qualitative studies. I just read one a couple weeks ago by Bohm, and they were looking at how evidence is translated, and they interviewed people that were doing really it was a public health transformation. But it struck me that one of the themes that came out of the interviews was, you told me what, now tell me how. Okay, because it's just not that easy. So I'm going to talk a little bit about implementation science and how we need to think about how we're translating our evidence before we ever get the proposal submitted. We've got to figure out who our stakeholders are and how to translate it. I'm going to talk a little bit about pragmatic designs and apply some of the work that we've done and talk about some of the lessons learned. I mean, we are continually learning from the work that we do. We are just never done. And then end by telling you a little bit about some of the infrastructure. So we need effectiveness studies, we need pragmatic designs, we need implementation science, and we need to build infrastructure to help us all grow together and learn together around how to engage patients and how to focus on the topics that are most important. So let me just start by an implementation study. So these studies that I'm going to talk about are studies that our team has conducted within the last 2 years, from 2012 to 2014. And this first one is an implementation study. It was called Nurse-Led Intervention to Improve Screening and Treatment for Substance Abuse, a cluster randomized trial. And this study compared, I should introduce you to the team. I worked with a wonderful group of colleagues, which includes a couple colleagues, one from University of California, San Francisco, Jason Satterfield, and Bonnie Spring from Northwestern University, another wonderful psychologist that both work in the well, they're both psychologists, and they both have some expertise in transition of substance use interventions to promote decreased use. So myself, Catherine Ferneely, Meg Johansson, Karan Burda, Yulan Liang, and Nare Han were all part of this team. So here's the issue. It was pretty clear in working with Jason, Bonnie, and some of my clinical partners that when they screened patients, the incidence of substance use in acute care was pretty high when patients were admitted. But what was happening was we would ask in nursing assessment, do you drink alcohol? And the patients would say yes. You know, I drink 20 drinks a week. But then it would be recorded on the assessment form, and nothing would happen with it. If they reported a substance, nothing would happen with the information. So this was an issue, and then the Joint Commission decided that they were going to consider screening, brief intervention, referral for treatment for substance use as a Joint Commission core measure. And they also published some information that 32% of hospitalized patients screen positive for substance use, and yet we know that there are interventions, screening, brief intervention, referral for treatment, that work for patients to decrease comorbidities, decrease harm. And yet, we weren't fully implementing that procedure, and nurses weren't fully implementing that procedure in the clinical arena. So since we knew the stars were aligning, since we knew there was a gap, and since we know that nurses can do this, we designed a cluster randomized trial, and it was a small one, 7 hospitals that were close to Maryland. And the intervention was one in which, when a nurse is trained in any new procedure, expert in this case, we train them, we observe them, we make sure they have the competencies, and they go forth and do. That's usual plan, do, study, act, quality improvement within the clinical arena. But in this case, there was evidence to suggest that if you use the evidence-based practice approach, so if you introduce nurses or you introduce providers to the evidence on which the intervention is based, that you work with them to tailor the intervention, that in fact the implementation would be better. There was a 10% improvement in other studies in the adoption of evidence when an evidence-based practice approach was used. So that was our intervention. And Bonnie and Jason and I had done some work in that area. So the intervention arm was related to the collaborative and the training, all related to training from the evidence-based practice approach. And the control arm was typical training of nurses in these clinical arena. And the target was adoption of reliable and valid screening for patients for alcohol and substance use. And improvement in the adoption was the target. We used nurse survey, nurse expert fidelity. We conducted fidelity measures both in terms of intervention fidelity and implementation fidelity. We conducted medical record reviews. We randomly selected days to survey nurses about what they did on their last patient. And at the end, we had a coordinator phone call. So this was an implementation study. And what we found is the importance of tailoring. So even at the first collaborative, even though the control and the intervention group attended, the importance of tailoring the intervention to the clinical arena became really important. We've done a couple cluster randomized trials and have discovered the same thing, and maybe it's not discovery anymore. You have to tailor. That's the bottom line. So this was just an example of one of the instruments that we tailored to help nurses through the protocol. They told us we need materials to give to our patients. So we provided information so that they could tailor their intervention, their brief intervention, to the patient, about the patient's risk and about tips to reduce substance use or to help get them the help that they need in terms of referral. But we created a readiness roller that the nurses carried with them, a very easy algorithm to follow. We didn't ask nurses to conduct a full screening. We did the single question that is highly sensitive to predict substance use problems. And that's the question for a male over 65. How many times in the last year have you had 5 or more drinks in a day? And for women, how many times have you had 4 or more drinks a day? And most of you that are in the psychiatric arena know that those are indications of binge drinking. So this is a screening question. So it's not going to catch everybody. But then if they screened positive, then they went to the second level and used an audit scale, the alcohol use disorders inventory. So what we try to do in our interventions is we try to pull down the evidence to the least a nurse can do and then screen to a higher level of care. And I think this whole tailoring idea is really what helps nurses implement it. So at the end of the day, at the end of this study, nurses said, oh, I can do this. Yes. It takes me, let's see, about 3.5 minutes, 3.5 minutes to screen. Brief intervention was a little interesting, but it was about the same time. But the screening itself really didn't take that long, which I think is really good news for us. They said it was doable and implementable. But the other thing I want to say is in these implementation interventions, it truly is a complex intervention, which, of course, anybody that does randomized controlled trials is going to start to talk about the threats to one of these pragmatic trials. But it is, in fact, how we understand the effectiveness of these interventions. But the complexity is that in a trial like this, it's about the nurses and what the nurses do. So they're a target, they're a subject. But it's also about the health system. We always do a baseline assessment with all of our studies so that we understand how ready organizations are to launch the intervention. And then the patients are really nested within that healthcare system. So there are really 3 targets in this kind of study, which make it a little more complex for us. So that's just an example of one of the implementation science studies that we have conducted. And just to tell you the bottom line on this is there was no difference between the control group and the intervention group. And what do you think the active ingredients was that they told us? It's the toolkit, right? So it didn't matter if we used the evidence-based practice approach. It didn't matter if we used the typical approach for nurses. They did equally as well. We had significant improvements in screening. So the went from about 20% up to 54%. So this is really good news for us in the medical record reviews. And I think the exciting thing is that nurses said, we can do this. It's easy. And we have to hear that word when we're thinking about designing these implementation science interventions. So great news, more patients are being screened. Nurses can and will implement this protocol. They can conduct brief interventions. And the other, in our interview, 4 of 7 sites are going to continue to use the protocol and spread the protocol. Some of them embedded it within their medical record. But it clearly changed the general knowledge about alcohol and drug screening and demonstrated the value that nurses bring to the organization in terms of the ability to identify patients that are appropriate for brief interventions that will work and for referral to treatment when appropriate. But I also want to note that there's a lot we know about implementation science, but there's a lot we don't know. It's really in a nascent field. But when we designed this intervention, we went back to implementation science and said, what do we know that we can bring to this study that will help us design this intervention to make it more effective? So this is just a list of some of the implementation science targets for interventions. So cognitive factors. So we focused our training and competency verification. So we not only used training and return demonstration, but we used observation that nurses actually were able to complete the protocol. We used motivation. We have a Joint Commission metric that is now, it's part of the Joint Commission portfolio if organizations choose to use it. Plus the motivation of the organizations that were working with us, and I don't call them sites, I call them partners because they truly are partners, and we continue the relationships long after the studies are done. We focused on behavioral implementation strategies. So, and the behavioral was skill development, the toolkit, responding, tailoring to them, and we taught them motivational interviewing techniques. We used professional networks, so we had synchronous meetings monthly. We used organizational networks, assuring that leadership support was available for before the implementation started. We also, every study we do that's an intervention study, we always give the data back to the sites. So we aggregate data back to the sites about their performance as well as a comparison to the other sites, and it creates just a wonderful, wonderful learning together. And then we also assure that there are organizational resources to conduct the study before we ever get started. So just to call those out. And just if you are interested in a concise implementation text, this is wonderful. This is a wonderful text, and it's from Strauss, Tetrow, and Graham, Knowledge Translation in Healthcare, Moving from Evidence to Practice. And I know they have a new book coming out, and I'm not sure if it's out yet, but it brings together and it gives you some tables of some of these strategies that can help you. And then we know a fair amount about barriers to knowledge use, and we've certainly seen in nursing that we have issues with organization, with timing, with communication, and sometimes our personal factors. So these aren't unique to us, but this is another area that we need to consider is the barriers that these sites will need to overcome, or the nurses or your subjects will need to overcome. And we've got to think about those in an implementation study before we get started. And then, again, some typical interventions that are used in knowledge translation, educational. Our project was educational, linkage and exchange kinds of projects. Audit and feedback is typically used in quality improvement. Informatics, actually the sites that embedded the protocol into their medical record, it's not a surprise that they did better. Engaging patients, I'll talk more about that. And, you know, I really think that we've got to make sure, even if we're conducting an efficacy intervention or an effectiveness intervention, we have to pay far more attention to the organizational context, because often that's one of the reasons we don't know where an intervention works, because we don't know under what circumstances, what was the context like. And then monitoring and evaluation is, of course, another KT intervention, knowledge translation intervention. So, implementation science is not for the weak of heart. I would say that 20 years ago, people wondered if, in fact, it was a science at all, but it is. Too many studies have not been implemented when they should. We've spent millions and billions of dollars on effectiveness studies that never had uptake. So we've got to do a better job in this arena. So this picture actually is from New York a couple years ago, and I just loved it. It's at a soup kitchen. If you know the Steinfeld, I think this is the soup kitchen, and I just had to go there. And here's this sign. So if you can't read the sign, we're going up to the soup, and it says, for the most efficient and fastest service, the line must keep moving. Pick up the soup you want, have your money ready, and move to the extreme left after ordering. That is the way that soup line worked. Well, it doesn't work that way in practice, right? We can't tell someone what to do, and it happens. We've got to attend to the science of implementation. We've got to learn from the science of implementation, and we've got to pick the strategies that match the intervention we're trying to implement. And that goes for translation in terms of translating the evidence to practice, and it also goes for the generation of knowledge around what works and how we can move evidence to practice more quickly. So that's my implementation science endorsement. And I just want to quickly tell you a little bit about a second study that just actually finished last June, and that's Improving Heart Failure Outcomes study. And this study was conducted based on a cluster randomized trial that we completed in 23 rural hospitals. And at the end of that study, the nurses said, please come back to us with a standardized protocol. So the intervention in that study was a quality collaborative. And they loved the quality collaborative, but they wanted more. So we designed a study that we were submitting for funding, and about the same time, American Nurse Credentialing Center had been asked by many of the magnet organizations to fund a multi-site study. So it's really a crowdsourced study. So the organizations paid ANCC to support this study, and our study was chosen. And the study really is, and I shouldn't go any farther without acknowledging the research team. And we continue to work together. So this study was really around standardizing guideline-based care. American Heart Association has heart failure guidelines in 2013, very clear about what should be implemented in acute care. In acute care, how many of you in acute care are aware of implementation of readmission reduction interventions? Anybody out there? Anybody in clinical care should have their hands, because everybody's trying to figure out how to crack that nut, right? So this study was really providing the best tools around helping nurses deliver what's in the guideline-based care. And we made the decision that it would be a quasi-experimental study. We thought about randomizing, but the magnet hospitals are pretty well linked, and not only that, it's crowdsourced, and each one of them need to have their own value, right, out of this, out of participating in a research study. So we made it quasi-experimental, pre-test, post-test, so it's one of the weakest designs in terms of intervention studies, but it provided these tools once again around providing care for heart failure patients. We also had a goal to identify the hospital and nursing characteristics associated with improvements in patient care and to evaluate the cost effectiveness of this guideline-based care for nurses. So 40 hospitals participated. 587 patients were recruited. We measured we delivered a knowledge test, Dutch heart failure knowledge scale, before and after patients received their education. So at baseline when they were admitted, these are patients admitted to the hospital with heart failure, and before they left, another Dutch heart failure test. And then we also measured patient self-care at baseline using the Self-Care Heart Failure Index by Regal at baseline and at 7 days. And of course, we were also interested in readmission. But really, this was nothing but guideline-based care. And during this intervention, the guideline-based care was delivered 95% of the time, so there's very little variance in not delivering it. But really, here we go. Once again, it's the toolkit, right? It's the toolkit with the teach-back mechanisms. It's the feedback loops for the data, not only the data from the patients, but the data from the context, the practice environment scale. So we were able together to look at the practice environment scale and the domains. We were able to, looking at evaluate the adoption of smoking cessation counseling by nurses and talk together. Look at some of the core measures and the core measures were all high, very little variance, quite honestly, around some of the nursing factors, hours per patient day, and nurse turnover. So it created, again, this very rich dialogue, and the bottom line is the study ended in June. We're still analyzing the multivariate data. The bivariate data certainly indicates that there's knowledge gained pre-post, but at one point, and knowledge gain might be significant, but is it clinically relevant? The self-care did improve, but there are probably reasons for that. We didn't see much effect on readmission at this point so far, but I can say that the general average for readmission nationwide for heart failure patients is about 25%, and in this study it was 22%, so probably not a significant number, but it was lower. But as we continue to work on these multivariate models, I think, you think about a study like this, and you're always facing the analytic challenges of how big is a cluster, right? And what needs to be in the model. So that's what we're dealing with now. But what I'm going to say is that I get really excited about the collaboratives when the nurses come back together. We always have a collaborative at the beginning where we come together and at the end of all our studies. And the stories I hear, I'm not a qualitative researcher, but I can't help being awed by what's happening in the clinical arena just by activating people by the use of evidence and us learning together. So you can see why I'm becoming a learning healthcare system zealot. I've just seen again and again some of these amazing outcomes. So when we do studies, they're outcomes, they're primary endpoints that we study and secondary endpoints. But something happens when we conduct a study, and we must attend to this. And this time, we were conducting the final interviews on the phone. I got so excited I had to stand up a couple times. I just couldn't believe what I was hearing. And when they came back from the collaborative, there was just as much excitement. So, when I think about generation of knowledge, I've got to say I find myself being like a chameleon, because sometimes it really is about the evidence translation, and sometimes it really is about the generation of knowledge we need in practice. But the examples they gave is actually the first paper, so it's not the paper that has our results in it. It's these stories that were pretty amazing. And so we talked with a group about what we wanted to do with these stories. And 12 of the 40 hospitals, there were actually more, but 12 of the 40 actually submitted cases about what happened. And this wasn't part of the research study. This was just telling the quality story about what happened as a result of the data. And Meg Johansson and I looked at the data and we said, man, this just fits the knowledge to action cycle. What happened here is the knowledge to action cycle. So in this knowledge to action cycle, there's a center core. So those of us that are scientists are creating knowledge. And this is the knowledge that is synthesized to create products and tools. And you see along the center of this that there's tailoring of the intervention. That's exactly what we do in all of our studies. So we create this knowledge, but as soon as the knowledge is created in these studies, it goes to the practice arena, to our partners, just because of the way we do business. The practice partners identify the problem, and the cases that they gave us fit into each one of these steps in the knowledge to action cycle. So we conducted this study. We gave them evidence-based tools. We created the resources. We listened to them, and we gave them what they needed for the patient and for the nurses. So we created the tools, but then the action started. So the first step in the translation phase of this model is adapting knowledge to the context. And just one example I'll give you is that when they received the low literacy education materials for patients, one site said, whoa, we've got to do some work on our education materials. So they created this new booklet. They launched the new booklet. The patients loved it. They got lots of good responses from it. Greater than 95% of the patients absolutely loved what they did. But what they did was a result of just receiving the low literacy training for patients, or the components are best practices around low literacy training. So that's just the example of adapting to the local context and their needs. Assessing barriers and to knowledge use is the second step. And an example is when they assess the barriers to implementing the knowledge for patients, they looked at their system and they found that they really needed to put somebody in a position to help leverage some of the information exchange with the patients. So one site tells a story about implementing a heart failure navigator because of these complex systems. Another implemented a flow RN into the system. So they assessed the barriers to how to areas they were having trouble, and then implemented and adopted this new strategy. Then in terms of selecting, tailoring, and implementing interventions, some of our sites found that patients don't have scale. So, of course, you're asking the patient to weigh themselves every day and call their provider if there's more than 5 pounds difference in weight in a day. And so they actually worked with their auxiliary, and every patient that leaves that doesn't have a scale has a scale. So they tailored the intervention to their own site and their own needs, and there are other stories with that as well. So in terms of monitoring knowledge use, one of the ahas in this study was, number one, how many of their patients were being readmitted. So when they actually saw the patient and knew now they were readmitted within 30 days, it created a different kind of learning. And the other thing we found in this study is that 24%, and the patients that were in this study are patients with mild to moderate heart failure symptoms. So New York Heart Association class 2 and 3 were most of them, for those of you that are in that arena. So what happened as a result of the readmission focus then, but the other thing is 24% of the patients in our study had depression using the Beck Depression Inventory. it was a shock. So Sue Thomas was on our team. She's done a lot of work in the relationship of depression and outcomes and said, you've got to use the BEC, and she was exactly right. So some of the organizations were shocked. They set up new processes, and many of the organizations now embedded depression screening into their assessment as a result and are now monitoring those outcomes and evaluating the outcomes. Then in terms of sustaining the knowledge use, at the end of the day, many of them created new positions based on what they learned in this organization. So they're focusing on the things that are important. Many of them are creating ongoing education. Some of them created mandatory education for heart failure in their organization as one of their competencies. So I could go on, but I just am saying that even though we conduct a pragmatic effectiveness study, there is more happening with our clinical partners, and take advantage of that and listen for it, because that's a way really to leverage the value of the studies that we conduct. So out of the IHO study, we actually were fortunate to receive a funding for an R24, which is an infrastructure building grant that I'll tell you a little bit about. But we have a sub-project to tailor this IHO intervention to the rural arena. So we are going back to our rural partners that worked with us in our first study, but we're doing the tailoring in 2 rural hospitals in Virginia. So we had the pleasure of meeting with them in January, and once again, being in the site, talking with the nurses, hearing their stories, hearing the special characteristics of their patients, walking around the rural hospitals, one of which has an average daily census between 10 and 20, and another between 60 and 70. So you can imagine the magnet organizations that are predominantly larger. Some are small, but they're predominantly larger, and they are used to doing research, going back into a rural hospital that is naive to research. It is exciting, and I've got to say that these partners are absolutely amazing. But I have to tell you that we learn so much from the IHO and the SBIRT study, and we apply what we've learned in the next study. But the other thing I have to say is we always assumed that the outcomes we were measuring were the outcomes that were most important to patients. And the more I've been involved with the Patient-Centered Outcomes Research Institute, the more I realize that we've never asked them. So in this study, the first step is to interview patients to make sure that our comparators are the right ones, the outcomes are the right ones, that we're focusing on important content. And before we ever move forward with launching the intervention, we will make sure that what the patient says is important is included in this protocol. So this is just us last month working with one of the sites. So this is exciting. I've got to say, there's nothing more exciting than seeing nurses add value and think about how they can implement the evidence in their practice setting. But tomorrow, I know there's a funding panel, and I'll have the privilege of talking a little bit more about PCORI. But I just want to put it on your radar screen. When you think about value, I'm asking you to shift your lens here. Shift your lens. It's not what we think is important. We've got to ask ourselves these questions from the lens of the patient. Given my personal characteristics, conditions, and preferences, what should I expect will happen to me? What are my options, and what are the potential benefits and harms of the options? What can I do to improve the outcomes that are most important to me? And how can clinicians and care delivery systems they work in help me make the best decisions about my health care? So think about the perspective of your research. Think about the perspective of your questions, because in the implementation science arena, unless we have the patients on board, unless we have the providers on board, it's not going to get implemented, which is the key to why some of these wonderful, effective interventions have not worked in practice. So I would be very happy to talk to any of you further about some of the work from Pecori. But very quickly, one of the last things that has happened is we received an R24, which is infrastructure building grant from Agency for Healthcare Research and Quality last October. And our grant is led by Dan Mullins, is the principal investigator. I am a co-investigator, and our infrastructure is called Patients. So go figure. So, patient-centered involvement in evaluating the effectiveness of treatments. And this center is really focusing on comparative effectiveness, so it's a comparison of 2 interventions for treatment, diagnose, or monitoring health conditions, just to remind us. So comparative effectiveness plus engagement of patients is patient-centered outcomes research in this definition. But I also need to say that one of the things that Daniel has done is he has done a lot of work engaging underserved populations and hard-to-reach populations. And Daniel has developed in JAMA, it's Mullins, 2013, it's either 12 or 13, a 10-step process to engaging patients. So we in patients, in all of our studies, have highly active engagements of patients, not activation in the intervention. I'm talking about engaging patients in our programs of research, asking those questions, defining the comparators, picking the outcomes. And it is, in our center, truly a win-win. So you can see this trajectory. The patients help us generate the topics and research questions, choose the outcomes, choose dissemination mechanisms of results, and that there's a dynamic relationship in this work we're doing. So here are the aims of patients: sustainable partnerships. We're going to conduct and expand PCOR in our campus and bring as many people along as we possibly can, and we want to advance dissemination and implementation, and as you might guess, that's one of my favorite aims. So in the implementation and dissemination aim, we are going to develop some infrastructure for dissemination and implementation. We are going to build some of this digital infrastructure for data mining. We're going to provide mentorship for faculty, and we're offering tools and methods for implementation and dissemination. So exciting work that we're just getting started. So some of the my work is related to the third aim, implementation and dissemination. I just have highlighted some of the best practices in implementation science here, but would also say there's a long way to go, that all of us need to know where the gaps are. There certainly is a need for a core set of implementation concepts, and I just would refer you to GEMS, who has a repository of measures, and I know, let's say I had a number for GEMS, but they have had pretty good uptake of their work. And there are a number of measures that you could get. Yes, 886 measures, and 346 constructs are available to you freely. So take a look, GEMS, out of National Cancer Institute. So they're going a long way to bridge this gap. We need some standards on implementation methods. So what is included in an implementation study? What has to always be there to make it an implementation study? And we need some reporting standards for implementation studies as well. So I just introduced you to a few of our patients' partners here, Association of Black Cardiologists, Patients Like Me, Riverside Health System, which is the rural network that I'm working with to tailor our intervention, Westat, University of Maryland Medical Center, Mount Lebanon Baptist Church, CMPT, and Bon Secours. So there's plenty of room for partners. The idea is these are partners, not subjects. These are long-term sustainable relationships, and we have already started to spur a number of ideas about studies with our partners. So exciting work. So in conclusion, I just want to say that how many of you came here on a plane? All right. So imagine coming here on a plane that's like our healthcare system that I described when I started. The pilot could have used a safety list, maybe not used a safety list, right? That wouldn't even be tolerable in our mind. And how many of you have used an ATM in the last day? All right, well, not too many, so maybe the statistics are not so high. So imagine not getting your money right away or not getting your receipt, and the record's being lost. Or you get your money a couple days from then. Okay, that's sort of what's happening in our healthcare system, right? We have these disparate systems. So we have a lot to fix that really isn't tolerable in our personal life. So it's time for us to really focus on value in healthcare. So what I would say in closing is we need effectiveness studies and we need implementation science studies, and we need them pragmatically in the clinical arena in partnership with providers and in partnership with the patients. But let's focus on the big rocks, right? The big problems first, where we can help the most people and have the biggest return on investment. And we've got to focus on using solid methods so that our results are believable and adoptable in the clinical arena. And then I know Kathleen Stevenson's here, and I said when I came to the Improvement Science Summit, I took this picture because it's here in Texas. I asked her what building, and I'll have to call on her later. But one of the things I do when I get somewhere, I have 2 daughters, 2 son-in-laws, and a husband, and I take a picture out of my window and say, view from my window. So this is when I was here in San Antonio for the summit with Kathleen Stevens. And one of my son-in-laws is attached to his technology, and they live in a townhouse about an hour away from us. And within a minute, I get this back. A minute. And I can't stop showing people this picture because I think, my view is not the view of everybody. We have got to include patients in this. We've got to start asking patients, am I doing important work? How can I disseminate this? Because just like you said, it's about the patients. Because for me, these are 2 fine men in my life. One's my father and one's my grandson. I want them to have high value-based care. And I know we in nursing have a duty, we have the responsibility to generate the evidence and translate the evidence that's important that my father and my grandson get the care they receive, and yours too. Thank you.